Good afternoon, everyone. This is Estella Balderas from Midwest Age Training and Education Center. Can you please just let me know if you can hear me? I believe you can, but I just want to check. So today we have with us speakers Linda Ligenza and Shaleyah Floyd, and we will be recording this session. Oh, thank you. So we will be recording today's session, and we'll have the recording available on the PHIMC website. So just to let you know that we will have a post-program evaluation, and I'll have the link up at the end of the webinar. And we are offering CE, Universal and Nursing CE, for a fee of $10. And I will have instructions to you at the end, and I will be emailing instructions to you as well. And please know we will have a few polling questions, and they are anonymous. So just, a couple little questions that we have, and they are fully anonymous. So Linda, I'm going to go ahead and pass the ball over to you. 1 second.
Thank you.
Okay.
Thank you, Estella. And good afternoon, everyone. We're so pleased that so many of you have been able to join us this afternoon. Just trying to, okay, good. So we're not going to go over all of these learning objectives for today's webinar, but I think one of the important things is we hope to really share with you some very practical trauma-informed approaches, some of which you should be able to use to, to implement the strategies associated with ending the HIV epidemic that Shaleyah is going to talk more about later on. So what we want to do today is to provide a little bit of an overview of the original Kaiser CDC ACE study, as well as share with you the findings and implications related to the more recent Philadelphia Urban ACE study. We want to really talk about the link between what we know about trauma and HIV, as well as how trauma shows up in the people that you're working with, and what are some of those challenges. As I mentioned, we're going to do an overview of the ending the epidemic HIV plan, and really talk about what we mean by trauma-informed approaches, principles, strategies, leaving you with some thoughts about what you can do for your next steps. We'll also have a number of resources that we think will be really helpful. So I wanted to start out by just providing a kind of a brief overview, and we're going to go more in depth into these throughout the webinar, but it's really important to note that all of the research, makes a definite link between trauma and prevalence of HIV, as well as poor outcomes related to HIV. The HIV epidemic is, according to one recent study, the highest number of people where the epidemic is really increasing the fastest is within women, but Black women in particular. So really important to note that. The Urban ACE study revealed that there are higher trauma prevalence among urban populations. And even though we're not talking about Philadelphia here, we certainly can, make the link between Philadelphia and other urban communities like Chicago. Of course, and I think it goes without question that one of the major challenges that all of you face really has to do with reaching, engaging, and maintaining people who are living with HIV in the treatment. And as I mentioned earlier, we'll talk a little bit about ending the HIV epidemic. But, the most important thing is that we know there's a very high incidence of trauma, and we really need to be using trauma-informed approaches. And we hope to share with you some very specific things that you could start to implement in your organizations at the end of the webinar. So we'll start with the Kaiser ACE study and also the Urban Philadelphia ACE study as well. So many of you may by now know all about the Adverse Childhood Experiences study, which was begun back in the 1990s by Kaiser Permanente in California, along with the CDC. And this was the largest population study ever done with over 17,000 adults. But this study continues today with variations. But one of the important things is that they found that almost 2/3, 2 of 3 participants reported at least one adverse childhood experience. And the other thing we know is that the more adverse experiences a child has, the more of an impact there will be, the more likely it is that they'll have other negative or many negative outcomes related to it. So some of those outcomes, as we see in this pyramid, have to do with social, emotional, cognitive impairments that's related to the adverse experience, followed by adoption of health risk behaviors, such as, multiple sexual partners, as we see in sometimes in people living with HIV. And then there is the disease progression, social problems like substance use, disease like HIV/AIDS, including early death. And when we talk about these adverse childhood experiences, we're talking about them beginning, as you see on that left side arrow, beginning in conception. We know that there's intergenerational or historical trauma playing a very big role, as well as the stress that the mother might be experiencing during pregnancy. And the negative outcomes related to these adverse experiences may show up at any time during the lifespan. I mean, people may be able to hold it together, do well in school. Most of the time, that's not what's happening, but it's possible. And then it may show up later on as a negative outcome, which we'll talk about in a moment. And so these are the indicators that the ACE study used. In other words, these are the areas that they asked questions about. And they included abuse and neglect, which was physical, sexual, emotional abuse and neglect, household dysfunction. So they were really looking at people that are living with you in your household, adults. Did they have a diagnosis of mental illness, depression? Was there suicidal behavior, alcohol, drug use, as well as was there the witnessing of violence in the home, especially against the mother, and also loss of a parent. And the loss of a parent was through 3 primary ways: divorce, abandonment, and incarceration. We'll see this issue around incarceration show up again when we look at the urban ACE study. But these are the 10 areas that the original Kaiser study looked at. And so what are some of the findings that came out of this study? Well, 2/3 of the people surveyed reported having at least one adverse childhood experience, and 1/4 experienced 2 or more adverse childhood experiences. They were looking at people who were over 18, but looking back on their childhood. As I mentioned earlier, the term that they use is a dose-response relationship between the adverse childhood experience and the risky behaviors. And so the more ACEs you have, the more likely it is that you will turn to risky behaviors like smoking, multiple sexual partners, physical inactivity, which all then lead to a variety of physical health problems, social problems, including HIV, AIDS, medical problems. And the last point here, it just goes into a little bit more detail there, but the last point, of course, is that connection between ACEs and things like cardiovascular disease, cancer, and HIV/AIDS. So this slide really shows us just a sampling of the possible physical health, mental health, social, behavioral issues, conditions that are associated with trauma, the impact of trauma. We see obesity, autoimmune disease, alcohol, drug use, suicide attempts. This is a really, really important one because what this all means is no matter what kind of a setting we have, whether it's a medical setting or a mental health setting, we really need to be screening for trauma because trauma could be related to any pain, people coming in with pain, those kinds of things. The other issue is self-regulation, anger management, and so it's really important in our programs that we focus on teaching people the skills that they need in order to manage these behaviors better. So now we're going to take a look at the Philadelphia Urban ACE study and some of the outcomes or findings there. And this study was led by the Institute for Safe Families starting in 2012. So it's a really recent study. And what they wanted to do is look at not just the individual adverse experiences, but what kinds of impact do community stress, adverse experiences, the toxicity that is often associated with some communities, what kind of an impact do those issues have on the outcome, health outcomes, and mental health outcomes. It was a relatively small study with only 1,700 participants, but they did have a very good response rate at 67%. One of the notable differences between this study and the Kaiser study is that in the Kaiser study, there were only about 5% of African Americans included because they were using the Kaiser Permanente participants, and they were mostly white. In the urban study, they looked at 36% of African Americans. The indicators, earlier I talked about what the ACE study looked at in terms of the sexual abuse, physical abuse, household dysfunction. The urban ACE study looked at the Kaiser indicators, but they also added 5 additional indicators that were related to stressors that they thought were impacting people in the community, such as bullying by a peer or classmate, witnessing violence, someone who saw, heard, or someone being beaten up, stabbed, or shot. And it's not just that they witnessed it, but they may have heard the sounds associated with that. They also included racism, that someone felt that they were treated badly or unfairly because of their race or ethnicity. People who had experienced, being involved in the foster care system and also feeling unsafe within their neighborhoods was another community factor they looked at. So I want to talk a little bit about some of the findings related to the study looking at, those community factors. And what we see is they 68% experience at least one of the nine of the 10 original ACE indicators. They dropped one of those ACE indicators. But I think it's really important to note that 81% experience at least one of the 14 measured ACEs. So when they combine the Kaiser and the urban indicators, they found that very, very large number of people, 80% experience at least one of those ACEs. and that 45% experienced at least one Kaiser and one urban indicator. But some of the specific data findings have to do with 40% of adults witnessing violence while growing up. That's a very large number as well. 34% reported experiencing discrimination, almost 30% reporting feeling unsafe, and over 37% respondents reported 4 or more ACEs. That's almost 40% of people with 4 or more ACEs, and we know that the more ACEs you have, the more negative the outcome. Some additional findings had to do with emotional abuse at 33%. Approximately 35% of adults grew up in a household with substance abusing, someone who is abusing substances. And 12.9% lived in a household with someone who served time or was sentenced to serve time in prison, which interestingly was looked at in the Kaiser study, but here, we see some pretty significant percentage of people who experience that. But what does all this mean? What are the implications? It's really important then, when you're dealing with large communities, you may not everybody may be in an urban community, but particularly in urban communities, you really have to target disadvantaged populations because those are the people who are going to be at the highest risk. And providing prevention and intervention approaches by using trauma-informed care is going to be a really important way of providing that prevention and intervention. And so now we wanted to talk a little bit about, what is trauma and how is it linked to HIV? So this is a really good definition. And by the way, we really like for you to be able to access these slides and use them in your organizations with your staff. These could be really helpful to you in, beginning that education process or continuing the education process around the connection between trauma and HIV. SAMHSA brings us this really helpful definition of trauma, talking about the 3 E's. Individual trauma results from an event, a series of events, or set of circumstances that's experienced by an individual as overwhelming or life-changing. And what's really important there is it has so much to do with the perception of the individual. 2 people may experience something very similar. Maybe it's a natural disaster, but they each will have their own way of reacting and responding to that event. And so we really need to value what each person brings to us in terms of their experience of trauma. And we also know that for many people, the trauma has a profound effect on the individual's psychological development, their well-being, and involves their physiological, social, and spiritual impact. And we talked a little bit about some of that already. And so the types of trauma, there are many different types of trauma that are possible, including medical, of course, HIV. There's complex trauma, and that's where we're talking about repeated trauma, such as repeated sexual abuse at a young age, or multiple personal losses, losses that may be related to divorce, or loss that could be associated with medical issues or disasters. It's also important to note that when we talk about the different types of trauma, we also need to include intergenerational or historical trauma, where there may have been a prohibition or destruction of cultural practices, like during slavery, the Indian resettlement, massive deaths. There may be sexual abuse, and so that trauma is not one that goes away when that person dies. That trauma lives on in the family and can show up in the next generation and in the following generations if there isn't adequate treatment and healing from that trauma. And as we mentioned when we talked about the Urban ACE study, there are different levels of trauma. We have individual, as I mentioned, historical, community trauma, societal trauma related to prejudice, discrimination, and including healthcare trauma. And so this is a place where we need to be very, very careful about how we engage people in care, what our environments look like, what our staff relationships look like with the client population we're dealing with. And so what we know about trauma is that it shapes everything about us. It influences a person's view of the world. It influences their faith, their spirituality. Some people get closer to God. Some people turn away from God. Identity, what people think of themselves, how they feel about themselves, their sense of self-worth, which is an important factor that I think shows up in the work that you're doing, and whether or not they even show up for care and take care of themselves and take the medication, and also impacts people's beliefs and feelings, including feeling unsafe and that people are out to get them. This is, I think this is a good slide for you guys to use in your work. I'm just going to go quickly through a couple of these, but when you look at healthy development versus people who have experienced trauma, we can see how it's so different. Experience is so different. So when someone who grew up in a healthy environment, they feel like the world is predictable and benevolent. But whereas someone with a traumatic development, they feel like people are out to get them. They don't feel safe. They feel afraid. They're hypervigilant and really worried that something bad is going to happen at any moment. It's really important in terms of, promoting health that people feel hopeful and optimistic. We're going to talk about that later when we talk about building resilience. So, one of the things that's, kind of important is what does trauma look like, especially as you see it in your organizations? How does it show up in the people that you're working with? Well, they have difficulty with their daily tasks. They may not be able to get to appointments on time, and that includes coming to your organization. And so we really need to be looking at our policies and procedures to ensure that we're not turning people away when they do show up. There's feelings of depression, anxiety. There's a lack of interest in pleasurable activities. There's often a series of somatic complaints. And we mentioned earlier what the impact that trauma has on the body. Inability to follow through on plans, which includes treatment, the treatment that you're suggesting for them, medications, those kinds of things. So we want to start with this one polling question and get an idea of where you guys are at in terms of assessing for trauma. So we're asking, does your organization routinely assess for trauma? And we're going to give you a couple of seconds to answer either yes or no. Routinely assessing for trauma. How are we doing, Estella?
Okay, we have, I think we can close.
Okay. I'm not seeing the results here yet.
Okay, well, I can tell you what the results are.
Oh,
Did you, I could tell you that out of the ones who said yes, 20 said yes, 16 said no, 26 are no answer.
okay. Okay. So I'm really happy to hear that 20 of your organizations are routinely assessing for trauma. At the end, we're going to have resources that are related to some of the tools that you can use to assess for trauma. And really, I think, if we had to just come up with one message, one important message here in terms of this webinar, it would be the importance of assessing for trauma and, using that information in your work with clients. So I'm going to go through some of these really quickly because we only have an hour for this webinar. But, child sexual abuse is extremely prevalent, both in women and men with HIV, living with HIV. We see that almost 1 in 3 of women in the general population experience child sexual abuse, but in the HIV population, it can go up as high as 75%. And, of course, we know that the higher prevalence of HIV is associated with higher health risk behaviors, such as unprotected intercourse, multiple sexual partners, etc. This is a very recent study that came out just in this month, where Eddie Mocktanger, the lead investigator, found that recent PTSD, we're talking about very specific symptoms. People who experience trauma don't always experience PTSD. PTSD, that hypervigilance, being fearful all the time, wanting to avoid the experience, the place where the trauma happened, those kinds of things. But what he found in terms of recent PTSD is 30% of women, HIV-positive women, experience PTSD, 5 times the national rate. Intimate partner violence, really important, again, to be assessing for intimate partner violence. 55%, 2 times the national rate. Child sexual abuse, 39%, again, 2 times the national rate. And child physical abuse, almost 43%, 2 times the national rate. So these are really, really important, such high prevalence rates that it's really, really important that we're assessing for these things, including PTSD. And so what is the impact on women? We see poorer medical outcomes, documented lower CD4 to CD8 ratios, more disease complications, poorer medical adherence, and also, especially in women, we see multiple stressors, including, maybe not enough social support, poverty, caregiving responsibilities. So we also need to be looking at these other associated stressors. In men who have sex with men and women, again, we see high rates of child sexual abuse. Child sexual abuse among gay and bisexual men is associated with negative health outcomes again and re-victimization. Men who have sex with men and women, and Black and Latino, are reluctant often to share, to seek care because of the stigma associated with their behaviors. And so we have to be really, really careful when we are doing an assessment, and to not at all be judgmental, and to really listen to what they're saying about their experience, because they may not have experienced it as trauma. And it's not necessary for us to define it as trauma, but to maybe make the connection between that experience and some of the behaviors that they have that are taking place in their lives today that may be impacting their functioning. And so, wow, the last 2 points are really important among men who have sex with men. 83% witness community violence, with 55% occurring in the last 3 months. This is one of the things that comes out in a number of studies, that it's really important to look at recent stressors, because those recent stressors are going to impact the outcome and the following through of treatment. 100% of trans-identified women said they experienced trauma. So we know it's extremely prevalent. And how it impacts people is in all of these ways. As we mentioned, high association with HIV, low adherence with medical care, self-care, also co-occurring disorders, medical disorders. As I mentioned, recent trauma or stressors is going to have an impact on, is related to significant predictor of antiretroviral failure. And high levels of PTSD and traumatic stress are associated with this population, and they often go untreated. And that's the purpose of this webinar, is to really expose you to what you need to know. And at this point, I'm going to turn it over to Shaleyah, who's going to bring us through a number of the next slides.
Okay, Shaleyah.
Good afternoon, everyone. All right, we're going to go on to a couple of the next slides. And thank you so much, as Linda said, for joining us this afternoon. And we'll talk a little bit about the HIV trauma and the continuum itself and folks that are living with HIV. All right. So as we look at folks that are living with HIV, and I've worked within the field for a number of years, I think many of us that have been in the field kind of identified over time that there was a relationship in finding out that our patients had experienced trauma as well as being HIV positive, and wondering, wow, there's a connection. Maybe other folks will identify this connection. So it's great to know that we're now moving towards how better to work with folks, provide resources and services, and be trauma-informed as we care for folks that are living with HIV. So as we look at the number, as I said, we may know or recognize that a lot of folks did experience trauma, that 70% of the folks that are living with HIV have experienced trauma. That's 20 times, and they're 20 times more likely to have experienced trauma than the general population. So I work primarily with women. I've worked with children, and 42% of the women that are living with HIV report physical or sexual abuse. Linda mentioned earlier about the sexual abuse and the ACEs study and that relationship, and kind of paralleled. And as we look at women that are HIV positive, knowing that that's 42% is almost half of those that are positive have experienced or reported physical or sexual abuse. We do know that the rates of trauma are higher among folks that are homeless. And if you've been working in the social service field for a while, the definition of homeless can be pretty broad. We initially thought homeless didn't have a residence, may have been living on the streets, riding the trains in the urban areas. But if you look at HUD's definition of homeless, I think we kind of tailored it down to folks that are either trading sex for housing, or people that don't have their name on a lease, or people that are maybe trading benefits for housing. So they have financial benefits that they then pay for housing, and because their name isn't on a lease, they can still get put out of their residence. So folks that are being trafficked, we know that that's an increasing population. It's been in existence, that those are also folks that are maybe HIV positive, and that's their risk of trauma. We have folks that are left at home because of physical, emotional, or financial abuse or threats, and they left their home environment for a safer environment or to avoid the abuse. So there's also the trauma and the HIV continuum, which talks a little bit about the diagnoses the diagnosis of pre-diagnosis of HIV, the diagnosis of HIV being linked into care, retained, or virally suppressed. So what we kind of, I would say, figured out over some time is that folks that are pre-diagnosed, that there's an increased risk in behaviors for transmission. At the Core Center, we work with our PrEP team, and we have a PrEP clinic so that folks that are at high risk can get resources, care, treatment, medication that will then hopefully decrease their risk for HIV infection. But we do know in our PrEP clinics that because those folks are high risk, that they also need those resources. Some of them may be homeless. Some of them may have experienced trauma, may currently be in a relationship with partner or intimate partner violence. A lot of those folks that come in for testing may hesitate to be tested, and one of their barriers for being diagnosed or treated or cared for is intimate partner violence. How am I going to share this information with my partner? Am I going to tell them? Are there resources that are available for them that may include partner notification? So if there's a partner notification with folks that they've been intimate with in the past, then they may feel safer about coming in to get tested, but they have to be aware of the resources that are available. So as you look at the trauma and the HIV continuum, that even looking at those that are linked to care, folks that experience trauma are less likely to link into care, whether it's physical care, mental health care, behavioral health, psychiatry, substance abuse, or for substance use. That population is less likely to get treated. So some of them, even when you look at retaining in care, people that are living with HIV may fall out of care based on their trauma. That coming in for treatment, for care, for medication, for resources may be re-traumatizing for them. Folks may come in more frequently and be hypervigilant as a result of their trauma. So it can go either way. So you'll have your folks that are coming in or calling or checking labs or checking viral loads or T cells based on their traumatic experiences and need the resources and support. So for our folks that are, and some of them are actually lost to care when they don't follow up, so we're trying to figure out what plans can we do to outreach them. We don't want to re-traumatize them when they do come in. I think Linda mentioned about policies and procedures that allow folks to come in for care. They may miss appointments based on their diagnosis, based on their trauma history, and how can we be supportive in allowing them to come in to get the care and treatment that's needed. So even our folks that have viral loads and come in for testing, we know that trauma is associated with poor health outcomes and adherence treatments and viral loads for folks. It could be from their CD4 count. It could be from the trauma experience itself, but those are some of the challenges that they face. So as I talked about resistance to seeking primary care, which would be not coming in for medical appointments, they are less likely to get tested, that there is some increase at times for mental illness symptoms, so whether that's depression or anxiety. Sometimes there's an increase in substance use disorder. We provide a MAP program here, which is your medication-assisted treatment. So for folks that have an opioid addiction, they can come in and get buprenorphine or Suboxone, but we've noticed that there may be an increase in folks who have a traumatic experience, who are living with HIV, coming in for care, and then trying to navigate all of those and in need of resources. So sometimes we'll have folks that come in and they're diagnosed later in having HIV or diagnosed with an AIDS diagnosis, which means that they either may not have come in for care or testing or had come in and gotten lost to care, but they may show up routinely in the emergency room for care, which then becomes their primary medical treatment. So I think Linda also mentioned some of the unhealthy coping mechanisms, from the risky sexual behavior, use of tobacco, alcohol, drugs, unhealthy eating, that there's a lot of things that go on in parallel with people seeking treatment and care for their HIV, as well as maybe the mental health or the substance abuse. So as we talk about the childhood sexual abuse and routine screenings for trauma and exposure to post-traumatic stress disorder, And one of our polling questions was specific to your agency in general, and kind of how you guys are or what you're doing about that, or if there is a screening or a mechanism for which you're evaluating that with folks that you're working with. So we screen for substance abuse here. We screen for mental health and suicide and intimate partner violence. I think in the assessment, sometimes what we notice is an agency may have multiple disciplines, and the assessment or the screening that's done to address or inquire about trauma may be done by a particular discipline, and that person or the folks living with HIV are only referred to that discipline if they meet criteria. So if a patient is referred to the mental health discipline at the core center, we're evaluating them for trauma. However, there are lots of patients that come in that we're not evaluating because they're not referred to that team. Are there other mechanisms at registration, or are there other mechanisms throughout the agency where this can be assessed? And more importantly, are we providing trauma-informed care regardless? So if you look at some of the written materials that are related to trauma, are they in the waiting room? Is there information available? Is there something about intimate partner violence and safety that's posted where folks can take information to go with them? Are the staff trained and educated in providing trauma-informed care? And is it more like a universal precaution that it's available all the time for all patients, not just those that are referred to specific disciplines? So Linda alluded a little to the ending the HIV epidemic, and I'm going to just provide a brief history so that folks are aware of what that plan looks like. So we're talking about the U.S. HIV plan overall, which is over an extended like a 10-year period. The goal ultimately is or some of the goals, I should say, are to reduce the number of HIV infections in the United States by 75% within 5 years, by 90% in 10 years. And over this time period, the focus is going to be that geographically is one of the areas, and that's because there are certain states that have high numbers of HIV in rural areas. So there are 7 states that will be the focus of attention for those. Obviously, all other states will benefit, but those will be the focus. The efforts will be more widely disseminated in the second phase so that 90% by the year 2030, the goal is to reduce the HIV infection. The third phase is to include the case management component, which is actually to kind of level off the number of new infections and make that fewer than 3,000 per year. So it's a long-term plan with numerous phases, with goals that we're to achieve and work towards. And providing trauma-informed care is absolutely necessary if we're going to meet these goals. If we want people to come in that are living with HIV for care, we're going to have to definitely provide environments that's conducive to that for both staff and for the folks that we work with. So the targeting plan itself of the gay and bisexual men in the population, if you look at just some of the data that we've listed, that in 2017, gay and bisexual men accounted for 66% of all HIV diagnoses and 82% of diagnoses among males. Linda mentioned African-American women, but specifically African-American and Hispanics. If you look at just the disproportionate rate of the data that's listed, it's alarming that being such a small component of the population that is such a large 43% of HIV diagnosis in 2017. And if you look at a map of the United States, looking at where the HIV diagnoses are, where there's more prevalence, the southern states tend to have higher percentages. And so those are some of the targeted areas in the U.S. plan that we'll be looking at. All right. The next 2 slides are very similar as they address what strategically the plan itself looks like. So it really focuses on early treatment. It focuses on substance use or needle exchange or syringe programs, early diagnosis and early treatment, and responding geographically to areas. So as I mentioned, the southern states geographically being able to identify that those are high-risk areas, and then applying services, resources immediately. And for those of us that's been in the field for a while, it's nice to know that there is a global plan, and we're able to see where there are hot spots, where there's HIV infection, and be prepared for those. And this slide is very similar. It talks a lot about the diagnosis, the treatment, the prevention, and the early and very quick response. So next we'll go into trauma-informed approaches, and I'll let Linda discuss those a little bit more.
Thank you, Shaleyah. And it looks like we're going to have to go through these pretty quickly. Let's see. Okay, so this is just, again, kind of a broad overview of the importance of the prevalence of trauma and the importance of really providing trauma-informed care to folks. One of the things that kind of stands out is that not everyone who's experienced a traumatic event ends up in the mental health, substance use, or criminal justice system, or living with HIV/AIDS. However, the majority of those served within those systems and those living with HIV/AIDS have a history of trauma. The other thing is that symptoms, the symptoms we see of trauma, are really considered adaptations to overwhelming experiences. And this is one of the things I think that can reduce the stigma that's often associated with people living with HIV and their behaviors. So really important that all the staff understands that when people were experiencing this trauma, they were trying to adapt, and they may have adapted behaviors like substance use that worked at the moment, but then stops working later on. But we have to help people understand why why people have gone to these behaviors in the first place. And as I said, that really helps to reduce stigma. But, where do we begin to, we're talking about changing our culture, oftentimes, and shifting the way we think and the way we talk to people from beginning to ask what happened to you rather than what's wrong with you. So we want to move away from any kind of judgmental behaviors and ask what's strong rather than what's wrong, really looking at people's strengths and building on those. These are the principles that were identified by SAMHSA, and I would say that if you could sit with your teams and look at each of these principles and think about how these show up in your environment and in the relationships that people have with your staff, and look at what kinds of improvements you can make in each of these areas, it would be so really valuable and move you really in a good direction toward trauma-informed approaches. Empowerment, for example, using motivational interviewing, collaboration, using shared decision-making. Are staff trained in those approaches? Are we providing a safe environment? People feel comfortable, safe. There's privacy. And, of course, building trusting relationships is extremely important. This is a really important slide as well, defining trauma-informed approaches. Remember, SAMHSA used the 3 R's when they talked about defining trauma. In defining trauma, what we mean by trauma-informed care or trauma-informed approaches, we're talking about the 4 R's. Realizing the prevalence of trauma, how trauma affects individuals involved in the program, organizations, as well as your own workforce. We want to ensure that we're resisting re-traumatization, looking at policies and procedures in everything we do, our environment, and responding by fully integrating the knowledge that we have about trauma into our policies, procedures, practices, and settings. So I want to stop quickly and ask you, the following staff in our organization have received trauma-informed care training. Is it physicians or clinicians only? Every staff person in your organization has received some trauma-informed training, or none yet, but we hope to do so soon. Just take a couple of seconds to answer.
Okay, polling is open right now.
And by the way, we have 80 participants on this call. So we saw earlier that 20 of the 80 said that they were doing routine screening for trauma. So it's okay. People have a way to go, and that's okay. You just have to start someplace and just keep the ball moving. Do we have some results there?
We'll give it a little bit more time. There's still a few people answering.
And Linda, I definitely agree in terms of keeping the ball rolling and even acknowledging the progress that you're representing your agency on today's call. And hopefully you'll be taking back information that you guys can apply. So acknowledging that there is progress and you're attending and sharing that information.
Absolutely. Thank you for that, Shaleyah.
Just a little bit more.
Can we stop it now, Estella?
Yeah, it's there's a few people still submitting responses, so
well,
counting down right now. We have about 8 seconds left, so. Okay. Okay.
Okay, I see here. So it looks like out of the 80 people we have on the line, we have clinicians only. I guess 62 people responded to the survey. So out of the 62, we have 13 who have trained clinicians only, 22, every single staff person. And we're talking about secretaries, receptionists, if there's security staff, everyone in the organization when we talk about who needs to be trained. And then there's 7 of the 62 that say that they haven't yet. So it looks like people have really begun this process, which is awesome. And we hope that this information we're sharing with you today is going to help you to continue this process. This could be a really helpful slide for you to use in your training with staff, looking at what kinds of behaviors might be re-traumatizing within your organization, like using stigmatizing or dehumanizing language. Even if it's just among the staff and you use the words non-compliant or no-shows or resistant, you're giving the message to the staff, the wrong message, to staff, that it's okay to use that kind of language, whereas you really want to promote, strength-based kind of language when you're working with staff as well as patients. So I think this could be a good slide for you to use with your, with your staff and when you're doing your own training. The benefits of trauma-informed approaches really benefits everyone in the organization, including the staff and the patient population, and really promotes organizational wellness. So the next couple of slides have to do with resilience, because I mentioned earlier when we looked at that paradigm shift that we want to focus on what's strong. So what are some of the strengths people have, and how can we build their resilience? And by resilience, we're talking about adapting well in the face of adversity, trauma, tragedy. And this is a definition by the American Psychological Association. But more importantly, how do we do this? Well, we do this by really, and I mentioned earlier about anger management issues, emotional regulation techniques, breathing, seeking safety, very important. So adopting these approaches and using them in your organization can be really helpful to your client population. Teaching self-care, spiritual, helping people to reconnect to spirituality, connecting with supportive people in their environments, family members. That is the most important thing we can do to build resilience. So whether you do that within your organization, provide opportunities for people to connect with others, or you help them do this outside, it's really important. Vicarious trauma, we all know, is really an important issue. So looking at your own staff and how to help them to be more resilient is also important. So when we talk about implementing trauma-informed care, we start with building an infrastructure. getting leadership support, forming a team, a TIC team, TI, Trauma-Informed Care, developing an action plan, collecting data, and looking at your policies and procedures. And I thought these would be 3 areas that you can start to look at: education, environment, and engagement. Educating all staff about the connection between trauma and HIV, the prevalence, and the environment, making your environment feel more safe, and also how you can engage patients in a more respectful, empowering, trusting way using motivational interviewing, for example. I see that we're at 2:26 right now, and I think this is a really important question that you need to ask yourselves. What is one new approach you will use with patients after this webinar? So what is one thing you as an individual can do differently? And is there one thing that your organization may be able to do to implement trauma-informed approaches? So think seriously, take away this information. What can you do, and what can your organization do? We also want to open this up for questions. We have a few minutes, so please write into the chat box, or you have the opportunity to raise your hand if you have questions. The list of, while you're typing in your questions, there's a list of resources here that are related to understanding trauma and HIV, resources related to screening and assessing for trauma, and treating trauma. Any questions yet, Estella?
None yet, but I'm keeping an eye out. If anyone has a question, you could type it into the chat box for all attendees. That way we could all see it.
And if you would, while you're typing into the chat box, if you don't have a question, it would be helpful to us to know if there's one approach you want to use with patients following this webinar. Anything yet, Stella?
No, I don't see any requests for hands up. I don't see any questions yet, but we'll wait a little bit more.
Okay. And while we're waiting, I'm just going to talk about a couple of things here. These resources can be really helpful for you and your staff. There's the SAMHSA concept paper on trauma and trauma-informed approaches that has lots of good information in it. Tip 57 is and you can get those from the SAMHSA store for free, download them. There's also the NASTAD Trauma-Informed Approaches Toolkit, which is specific to trauma and HIV. And there's a wonderful Nadine Burke-Harris TED Talk. She's a pediatrician who talks about the ACE study and how it impacted her work. There are many screening tools that could be used, but at these sites you can find those tools and other tools, including a PTSD screening tool. And, treating trauma, there's a bunch of websites there that you can go to, including Women's AIDS Project.
Okay, we have a question here.
Mm-hmm. Yep.
Can you read the question, our panelists? The chat box?
I can't see it. I can't see it.
Okay, well, I'll read the question. When training in trauma-informed approaches, would you recommend a blanket training for providers of all levels, clinicians, case managers, providers, or could it be different? What have you seen works best?
That's a really important question, a really great question. I think that what I've seen, and we've done through the National Council, my work at the National Council, we've worked with many organizations across the country to adopt trauma-informed approaches. And I think to start out, what a lot of organizations do is they use like an all-hands meeting, an all-staff meeting, where they're just kind of doing beginning trauma, what is trauma-informed approaches, so that everyone is present and everybody's getting the same kind of information. What I think is helpful as a follow-up to that is, using maybe some of those specific discipline meetings to now talk about how does this apply to me and my discipline, and what what can I do specifically? For a doctor, for example, changing the way they, talking to the patient about what's going to happen when they come into the exam room. What are they going to experience? Do they have any, particular needs, or have they experienced trauma, and might this be frightening for them? Those kinds of things. So talking to each of the disciplines, I think, afterwards, and, continuing the conversation is what's really, really going to work in organizations. Shaleyah, did you have anything to add?
Yeah, actually I did. We did the training of all staff, and we understand that it's time cumbersome, that it was a great experience for all staff, and folks were educated and learned more. I think there's a possibility of running into barriers in terms of how do you continue that. So for us, we're looking at now making that part of the onboarding experience. We do know that folks that come into the social service field, in a lot of cases, may come with experiences of their own that are traumatic, and even addressing that and how do we incorporate all of that and make sure that we're providing trauma-informed care for staff and for the patients we serve. So we're looking at doing it as part of the onboarding experience at the very beginning to catch the new staff as well as the continued training.
Okay, just one more question right before we sign up. We're slightly over, but I think we can ask one more question. This question is for Shaleyah. At your site, what is the most common trauma people living with HIV are experiencing?
And so some of the trauma could be the violence. And being in an urban environment, it's not specific to the HIV, but it could be based on their community. So we see a lot of folks in their communities that have experienced violence that are coming in for care and treatment. So those are primarily what we're seeing a lot of now. We have folks that are experiencing anxiety and depression, fear, phobias as a result. So those are some of what we're seeing that aren't specific, say, to the medication or the treatment, but impact their care and their ability to come and receive services.
Okay. Well, thank you so much. I think this concludes our webinar. So I'll ask if everyone can please go to our survey. The bit.ly link is there. You could just copy and paste it to your browser. If you could please complete the survey, this is so very important to us. The data we collect is very essential to the work that we do. So please, if you could please complete the evaluation, post-program evaluation survey. And I will be emailing out the CE request forms along with the instructions. I know that some folks were having a viewing party, which is, it's pretty nice, pretty fun. So if you could please send me a list of those people who attended your viewing party, that way I can make sure that they can request a CE should they, should they wish to do so. If anyone has any questions, please give me a call. My phone number and email address are on the emails. And that concludes our webinar. Thank you just so much to today's speakers.
Thank you.
Yeah, thanks. Bye, everyone.